All right, out of respect for everybody's time, we'll get started as I'm sure people will continue to filter in. My name is Kristen Pruski, and I have the honor of being the Vice President for Sibley Memorial Hospital's Foundation and serving on Sibley's executive team. Today, I'm so excited to introduce you to, though many of you like me have known Dr. Paul and are a grateful patient of his, to Dr. Paul and Suzanne Dutton to talk a little bit about surgery over 65. For those of you who don't know Dr. Paul's impressive background, he's the medical director for geriatric surgery at Sibley Memorial Hospital. He's an associate professor of surgery for Johns Hopkins, and he is the regional director of minimally invasive surgery for our national capital region. Dr. Paul earned his medical degree from Northwestern University, and he completed his residency in general surgery at Georgetown. He then went on to have a career with the U.S. Army Medical Corps until 1994. We've since had the privilege of having Dr. Paul at Sibley for 28 years, where he's served in many roles, including the Department of Chairman for Surgery and the Director of the Surgical Quality Improvement Program. He's a board certified in general surgery and is a fellow of the American College of Surgeons. Thanks so much, Dr. Paul, for giving some of your valuable time up for us today.
Thank you very much, Kristen, for that nice introduction. Welcome to everyone who's out there and joining us on this webinar. Thank you. Yeah, sorry, this is just a one-way video. It'd be nice if there were a way for me to see who's out there. I'm sure I'd see a lot of familiar faces, patients of mine who maybe have gone through our program here and hopefully can attest to its success. Next picture. So this is, I want to first recognize two people you've already heard about who've been really instrumental in getting this program started here today. Suzanne Dutton is a geriatric advanced practice nurse who directs our niche program. And she really is, as those of you know her, she has a long-standing passion and commitment to the care of older patients. And you'll be hearing from her on this webinar. And then on the right there is Rosemary Trejo, Sibley's first geriatric nurse navigator, who many of you meet if you are a patient here. And you see that also she has a way of developing a bond with patients and their families that really is special. Next slide. So this program is actually part of a Johns Hopkins system-wide initiative to improve the surgical care of older patients. And at Sibley, we were excited to participate because it turns out we actually have the highest geriatric population of all the regional hospitals. In 2019, 60% of Sibley's inpatients were over 65 years old. And in the United States as a whole, of all the patients over 65, it's been shown that half of those patients will require surgery at some point in their lifetime. And as you might expect, these older patients can be challenging to take care of when undergoing surgery because there's a higher risk of serious complications and readmissions. And then in older patients, there's always this particular concern about the potential for loss in cognitive function or functional decline. So it's important that we as surgeons follow a certain set of principles when we take care of older patients. If we summarize them here, they appear in a textbook on geriatric surgery. And first thing we have to recognize is that sometimes the clinical manifestations of disease are different in older patients. Older patients sometimes tend to have a higher pain tolerance, and that can sometimes lead to delays in diagnosis and maybe more advanced conditions. Older patients don't seem to handle severe physiologic stress as well. They have less reserve in their organ systems, like their hearts or their lungs. And that can make it actually difficult to overcome some of the challenges that we see in surgery and anesthesia. And for patients undergoing emergency surgery, the risks are many times higher. But you don't always have the option of avoiding surgery, like a gallbladder removal or bowel obstruction, because surgery sometimes is still a better option than non-operative treatments for many conditions. And then in caring for these patients, it's really important to pay careful attention to detail because older patients just don't recover from complications as well. Even simple treatment errors from medications can have serious consequences. And finally, this is a lesson for all of us that we really shouldn't view a patient's age with any sort of prejudice. When we look at patients, we try to look at their physiologic age, not their chronologic age. So we really have to have a good assessment of their overall condition. Next slide. Next slide, sorry.
Oops, I'm having difficulty moving it. Sorry about that. Oh my.
And Dr. Paul, we have a little pause. I think there's something off with your sound. So if you could maybe just pull in a little closer
Okay, sure.
for a little louder, that would be awesome. Thank you so
Okay,
much.
great. Next slide.
I think this is the next slide.
Sorry, just go to the next one then, Suzanne.
Yeah, I'm having problems moving it forward. Oop.
Okay, there we go.
Okay.
So as I mentioned, there's a lot of variability in health and performance among adults of the same age. On your left is a picture of my mother, who's 91, and she lives alone in a small village in Bavaria and still walks her dog 2 miles a day in the fields behind her house. People wonder where I get my stamina from, and I think this woman deserves a lot of the credit. Growing up with her, there was no sleeping in on weekends. She always had activities and projects planned that just always kept us moving. Now, the more typical 91-year-old on the right is a little less independent. She may require more assistance and more specialized mobility aids. So in cases like this, the differences are obvious, but sometimes the differences are a little more subtle and maybe hard to quantify. So we really need a scientific and objective way of determining a patient's functional status and their ability to recover from major surgery. Next.
I'm still having trouble moving forward. This has never happened, of course.
All right.
Hey, Suzanne, if you stop screen sharing, we can screen
Yeah.
share. Sorry.
Yeah,
Thank you.
Thanks.
Thanks everybody for your patience.
Okay, so yeah, this is this objective scoring system that we use now for elderly patients in trying to determine whether or not they need any special assistance. And so this is something that we screen for in all our outpatient surgical clinics in patients over 75 who require surgery. And there's 9 different variables that you can see here that we have our nurses assess. The whole process takes less than 10 minutes to complete, and it allows us to come up with a frailty score. And this Edmonton frailty score, turns out, is really very predictive of a patient's ability to recover from surgery and from any associated complications. And all our patients with a frailty score of a certain threshold are then referred to this program that we have developed for perioperative care. And we'll talk about this program shortly. Next slide. So once you have an ability to evaluate a patient's overall health and their frailty, you may want to try to estimate what the impact of a particular operation is on that patient's health. And this is a nice risk calculator that was developed by the American College of Surgeons to assess a patient's risk of surgery. And it's based on an analysis of probably over 5 million patients. And what this allows you to do is first, you can select the exact operation the patient is having. You have to know the CPT code, but that's something that's available to patients too. And then there's a drop-down menu where you can plug in 20 different variables about each patient related to the medical condition. You can't see all those variables because this is just a screenshot. But then after you plug that in, you can then calculate the exact risk of surgical complications. Now here in this example, we selected an 80-year-old female who has hypertension that is not well controlled, and now she's scheduled to undergo a laparoscopic colon resection. Next slide. So as you can see here, you can then get a prediction of what the risk of any particular complication might be. And so this is a nice framework for discussing risks of surgery with patients. And so in this situation, this patient would have a roughly 10% risk of a serious complication. The risk of infection would be 4.2%, and the risk of a blood clot is 1.5%. And the risk of being readmitted as a result of a complication is 10%. Next slide. Now, this risk calculator has also been further adapted to the care of geriatric patients. And you can also look at the risk of delirium, the risk of functional decline, whether or not you need new mobility aids like a wheelchair, and the risk of a pressure ulcer development. And this, you should know that this ACS risk calculator actually is on a web page. It's free and accessible to the whole public. You can print out a report that you can share with your family. I would caution you that it might be a little bit difficult to understand sometimes the context of this. You might need the assistance of your physician. So it's something that should be discussed together, but this at least gives you some objective information about the risks of surgery. And with older patients, it's important not just to discuss these generic risks of surgery, but you want to look at really what the patient's overall life goals and preferences are, because it's important to really align your treatment recommendations with these goals. And these are the results of a survey of older patients after having had a consultation with a surgeon about an upcoming procedure. And they were asked to summarize what was talked about in that consultation. Not surprisingly, the major focus was on fixing the problem. That's what surgeons like to do. They fix things. But there was really very little discussion with the patient about what was important to them. Just feeling better, being able to attend family functions, and being able to maintain function and independence. And so this is something that surgeons really have to become better at. And when discussing the whole process of surgery and the recovery process, we really have to focus on what matters most to the older patient. Not just survival, but how their life and daily functions are going to change as a result of surgery in the future. Next. And this questions prompt list has been a very helpful tool I found, for counseling older patients and their families about surgery. We're providing this to patients in our office. This is much really a tool for the surgeon as it is for the patient. These are the questions that should be asked with a physician and prompt a good discussion. Will surgery make me feel better? What will my life look like after surgery? What kind of care will I need after I leave the hospital? What resources does the hospital have to help me with the recovery process? Next. But for those patients that decide to go ahead with the surgery, they need to know at Sibley we really have the best possible program to get them through the operation and through the recovery. Every program, of course, needs a catchy acronym. And the one we have developed here is called the PRIME program, which stands for Pre-Surgical Rehabilitation and Integrated Medicine for Elders. And it's based on getting every elderly patient in prime condition for surgery, making sure that all their medical needs are met, and that, most importantly, their goals of care are always kept at the forefront. Next. So this is a graph, I think, that nicely illustrates what we hope to accomplish with our program, in particular the importance of this prehabilitation. Now, the red line shows how we've always done it in the past. The patient has no prehabilitation, they have their surgery, and then they literally drop off this functional cliff and then begin the slow and painful process of recovery. But with prehabilitation, you're improving the patient's strength and nutrition before the operation. So you're increasing their functional reserve so that they can better withstand the stress of surgery. To me, this has always made sense that rather than just waiting until the post-operative period to begin the whole rehabilitation, the most effective time for these kinds of interventions are before operation. Next. So this is how our PRIME program works. I know it's a very busy slide, but it's a busy program, and it's anchored by our nurse navigator, Rosemary Trejo, who will guide patients through the entire process, every step. And after they've contacted with her, they're going to then meet with, or at least have a detailed chart review with a team that includes anesthesia, physical therapy, nutritional services, pharmacy. And the whole idea is to have this team collectively screen for any vulnerabilities and then develop a joint care plan to correct any of these problems. So our geriatric surgery nurse navigator will do the initial preoperative screening. She'll do a baseline evaluation of cognitive function. She'll also assess each patient's support system and helps them work out all these goals of care and advanced directives. And she's also very involved in the post-operative period as well. She sees every patient each day while they're hospitalized. Anesthesia's role is to provide really a comprehensive medical evaluation. They identify and manage risk factors before surgery, and they will then refer patients to the appropriate specialists and get them really in optimal medical shape. The physical therapist will assess the patient's overall strength and really start the whole prehabilitation process. Our physical therapists use a program called MedBridge, and that allows them to generate a customized exercise program that they can actually, in the comfort of their home, continue that before surgery. And then the nutritionist, they obviously start for any start by screening for any nutritional deficiencies, and then there will, of course, be general recommendations for improving a patient's diet. But we're also integrating a new concept called immunonutrition. This is a special amino acid supplements that have been shown to stimulate the immune system and actually lower the risk of complications after major surgery. And then our pharmacist's role is to review all the patient's medications. We look for any kind of potential drug interactions. And then we'll also try to avoid any drugs during the patient's hospitalizations that could potentially cause delirium and confusion. Next slide. So this is Rosemary again, the person seeing the implementation of this entire care plan. And as I mentioned, she connected with patients before, during, and after the whole surgical process. And so patients are able to see that same friendly face through really every phase of their treatment. This is so important in elderly patients to have that connection. And in the same multidisciplinary team of specialists we talked about that meet with the patient before surgery, they are also there to provide ongoing reassessment of the patient's care. And because these patients tend to also have very complex medical issues, we also have the hospitalists, again, a team of internists who also round on these patients each day. Now, a lot of the post-op care we provide to these patients is designed to be very standardized and follows very strict evidence-based protocols. And we have a special program called ERAS, another acronym, which stands for Enhanced Recovery After Surgery. And this is these are all specialized protocols that really emphasize early ambulation. We get the patients out of bed, often within 3 to 4 hours of surgery. We get them started on food right away. And most importantly, we provide alternate ways of controlling pain. We try to avoid narcotics as at all possible, any other medications that can cause delirium. And then all these patients their outcomes are carefully tracked, even long-term after they left the hospital. And we then enter them into a database. Next slide. So we then come up with reports that summarize our outcomes. And we have a geriatric surgery quality conference that meets every other month to review these statistics and to discuss any adverse patient events. And this graph here now looks at the percentage of patients having problems that are particularly common in older patients, problems like delirium, falls, pressure ulcerations, complications. And of course, we also track whether or not they need some kind of transition to a subacute nursing facility. And we look at readmissions. So 51 patients have now come through our program, and this is some of our early outcome data. And fortunately, we've been able to keep the incidence of post-operative delirium very low because it's delirium that's really the driving force for a lot of other complications that we see after surgery, like falls or pressure sores. So we've basically kept those problems at zero. If you look at our results, you see, yes, we've had some complications. And there's an old saying in surgery that older patients may tolerate operations, but they don't tolerate complications. And that was generally true in the past because you can often end up with this cascade of further complications and problems that can have a life-threatening outcome. Fortunately, that was not the case here. In fact, of the patients that had complications, 100% of them had a complete recovery. And so I think what we'll ultimately be able to prove with this program is that we may not be able to prevent complications, but that by strengthening these patients before surgery, it will improve our ability to have them recover from any complication. Now, in the last parameter here, we focus a lot on preserving a patient's functional status and letting them return to independent living. And out of the 51 patients that we operate on, only 3 needed some kind of a transitional rehabilitation facility. So I think that speaks a lot about the care that patients were getting before surgery and actually during the hospitalization, that they were able to get back to the same home that they came from. Next slide. So this idea of having a specialized program for older patients undergoing surgery is something that's getting a lot of support from surgical societies, and the American College of Surgeons has put together a certification process by which hospitals can be identified as having special expertise for the management of older patients having surgery. And this whole verification process is very comprehensive, and hospitals have to meet actually 32 different standards of excellence before they qualify. And to date, only 3 hospitals in the entire country have got this certification. So we're now in the process of pursuing this certification. Next slide. And I think this is really a critically important goal, trying to standardize the care of older patients across the country. And if you go to a hospital that's been certified as being geriatric surgery verified by the American College of Surgeons, you can expect that you're going to have a prioritization on quality of life and a facility where they're going to be focused on your personal goals of care. Care there will be more patient-centered. There's going to be coordination with multiple specialists before, during, and after the surgery. And you can also expect that your care team is going to have ongoing collaboration and communication during the entire hospital stay. And all this together should really result in the highest possible quality of care. Next. So I'd like to give you a prime example of how our program works. This is a patient we took care of in the early days of our program. Mrs. M. She is a 78-year-old woman from Croatia who was a lovely patient, but had horrible diverticulitis. She also had a long list of medical problems that was 2 pages long, and no one wanted to operate on her. But eventually, surgery became unavoidable. So she ended up being our first prime patient. And of course, we wanted everything to go perfectly. And both the preoperative preparations and surgery went well, but unfortunately, she came back in shortly after being discharged with a bowel obstruction, requiring another surgical procedure. So she had a complication, she had a readmission, she had a reoperation, and all the ways that we traditionally measure outcomes, this would have been a terrible result. Next slide. But here she is today. I can tell you she wouldn't be here at all if it weren't for really an entire team of people focused together on strengthening her in advance for surgery and getting her in this prime condition. It was the intensive physical therapy and nutritional support she received that really helped her regain her strength so that she could withstand a second operation. So when things don't go as planned, that you really need the best possible care. I think just as important is how this program really empowers patients to believe in their own recovery. What gave her the strength and confidence to get through this complication is knowing that she had a huge team of people to support her. Those same people will be here for you and your family should you ever need surgery. Next. So in summary, what you need to know and do if you're an older patient having surgery, you want to make sure that you've developed your goals of care with your healthcare team and make sure they know what is important to you. You need to understand the value of rehabilitation and work with any physical therapists, nutritionists, and geriatric care specialists so that you can get yourself in the best possible condition before surgery. Choose a hospital and a care team that has specialized programs of care for older patients. And then please support your nurses and the educational programs that make care like this possible. Next slide. So we'll have time for questions later on. I want to now turn things over to my partner in this program, Suzanne Dutton, who is an advanced geriatric practice nurse, and she'll explain why specialized nursing care is so important for your recovery. Kristen will give her a more complete introduction. Thank you.
Thank you, Dr. Paul. I really enjoyed that one graph that showed the impact of the PRIME program. That was great. Thank you. So pleased to introduce Dr. Suzanne Dutton. She has her Doctor of Nursing practice degree and a Master's of Science degree, and she is a geriatrics nurse practitioner. She joined Sibley in 2013 through generous philanthropic support that funded her first role here, which has continued to grow. She has practiced as a geriatric nurse practitioner within our region since 1998. We are very, very thankful to have Suzanne here and all the tremendous work that she does throughout the hospital. I just want to remind those that have joined us that you can submit questions through the Q&A feature on the bottom of your Zoom screen, and we look forward to answering those as the presentations conclude. Thank you.
Thanks so much, Kristen. Can you hear me okay?
We can, thank you.
Okay, great. I'm going to try again with my slides. Of course, that has never happened, but luckily I sent slides to Annie about 5 minutes ago before the meeting. So thanks for doing that. And thanks, Dr. Paul, for that great presentation. Rosemary and I felt really lucky to be working with you. And so Rosemary and I are a 2-people department called NICHE, which is Nurses Improving Care for Health System Elders, which is a evidence-based geriatric nursing program throughout the country. Sibley was able to become niche certified in 2011. And then, as Kristen said, I joined as the coordinator in 2013. Rosemary and I work closely together, and part of the program is to educate nurses to specialize in geriatrics. And so we have over 100 geriatric resource nurses that work with us across the hospital, and several of them are directly involved in Prime. So first, Rosemary and I often get questions like, I'm 65, I'm not geriatric. And I just wanted to give a little background of why the number 65. And so I have a poll question actually for people to participate in. So the first poll question is, what was the average life expectancy in the United States in 1935? 52, 60, 65, or 75. And I'm sure most people know that this is the year that the United States implemented Social Security as a support for older adults. All right, can we see what people picked?
We've got a few more answers coming in here. People are really voting. I'll give it about 15 more seconds.
In my training as a geriatric nurse practitioner, my scope of practice is for people 65 and older. And so that number comes, okay, so most people say 1935, 52, 60, or 65. And the answer is actually 60. And so in the early 1930s, when thanks for that, in the early 1930s, when America was trying to figure out how they were going to design Social Security, they looked at several European pension plans that were in place, and they really focused on one in particular, and that one is from Germany. And in 1889, Otto von Bismarck, he developed this pension, and he decided that the support should really focus on people 70 and older. And in 1889, the average life expectancy in Germany was actually 40. So for those that are 40, if you live to be 70, that would be considered old age. And this is how the United States decided to come up with the 65-year-old age to start with Social Security. And even though now, so many years later, our average life expectancy is close to 80, we still think of 65 as being older adults, socially, politically, and that's when most of the programs, Medicare and Social Security, are in place. Of course, in 1935, the US had about 9 million people over 65, as opposed to 54 million today. And so that's socially, but physiologically, when we look at older adults, my slides aren't going again. All right, I'm gonna have to stop sharing and then have Annie do the slides. For some reason, it's not working. Sorry about that. So we're gonna have our second poll question. So this is looking at why we start really looking at focusing in at 65 physiologically. So the second poll question is, what percentage of muscle loss does the average person lose over a lifetime? And those are the answers. Okay. We have an answer. All right, 30%, which is actually correct. Although there is a study looking that 40% of people lose the muscle mass percent in their lifetime. And I even saw a study today that showed 50%. And the involuntary age-related loss in skeletal muscle mass and strength, we call it sarcopenia, is a major cause for frailty, is why I bring that up. And you can see at the on the the graph on the left, how much frailty does increase by age, and knowing that muscle loss is a major contributor to that. As Dr. Paul mentioned, we look at frailty very seriously as an indicator of how you would do post-surgically. There's a great study at Johns Hopkins that looked at about 600 older adults and found that frailty increased surgical complications following the procedures as much as 20-fold. So it is something that we look very closely at. And the second graph on the right, I like to put up because it is just, falls is something that we look at very closely in the hospital and as nurses are constantly trying to prevent. And you can see it's actually a very serious thing. And actually the incidence of death from falls is not getting better. It's increased by 30% in the last 30 years for those people that fall over the age of 65. So that is also something that we look at. Next slide. But I have great news. Actually, your lifestyle choice does have a major impact on whether or not you get in that category of being frail. And prevention is the key. As a nurse practitioner, we go through a lot of training of how to prevent illness on top of differential diagnosis and prescriptions. So identifying frailty and really helping people do modifiable lifestyle choices to help decrease that is really the key. And the other great news is that it's never too late. There is a great study at University of Illinois that looked at people only 80 and over, and they put them into an exercise, a very easy exercise routine over 4 months. They basically had a high-level chair and asked people to repeatedly sit in the chair and then stand. And that was the primary exercise. And over the course of 4 months, they made it more difficult by lowering the level of the chair. But in that, at the end, they showed a statistically significant increase in lean body mass. So even if you're 80 and you begin these muscle resistant exercises, you will improve your body mass, which will improve you from being labeled frail. The other really interesting thing is one of the major things we look at as you're aging is grip strength. So that grip strength obviously is your hand grip strength. And even though you would think it just assesses the function of that one muscle group, there is a ton of research out there that shows that it's an indicator of your overall body strength. And it's also been connected to increased fractures, falls, malnutrition, multimorbidity, and quality of life. And there's even people looking at making grip strength a biomarker in looking at aging and longevity. So the other thing to help decrease your frailty risk is to be active most days. Immobility is really one of the worst things. Of course, nutrition is always important. Lots of studies looking at the Mediterranean diet and by keeping your mind active. So that's not just reading on a daily basis, let's say, but trying to really figure things out and making your brain work. So that would be learning a new language, learning to play an instrument, all of these things. By doing them will empower you to have less frailty. And of course, when it comes to surgery, less negative outcomes. Next slide. All right, so post-operative care. And you will, if you are part of our program, you get a visit by Rosemary, of course. And one of the things that I would always say is to make sure you bring sensory aids. So that are glasses and hearing aids. People are often afraid, they leave them at home because they're afraid that they're going to lose them. And of course, they're very expensive. We do have something called a pocket talker that we use here at the hospital, which is earphones connected to a microphone. And we can use that, but it's also really important to bring those things with you. Also, do not bring your actual medications, but a list of your current medications. It's really important. We'll have the pharmacist look at your medications and align them with what we have prescribed here at the hospital. So we'll make sure that you're on exactly the correct dose and medicine that you need. Other easy things are photo ID, insurance card, phone charger, and Rosemary wanted me to mention especially comfortable clothing, being a previous orthopedic nurse. All right, next slide. Other things that we really focus in on in nursing is fall prevention. So every year in the hospital, there is between 700,000 and 1 million falls. Of that, 11,000 deaths caused by falls in the hospital. We have multiple teams that work on falls, multidisciplinary teams, and it's something that we take extremely seriously here at the hospital. Something to think about is just that most falls, when we're looking at the root cause, are people who are trying to get up by themselves to get to the bathroom. Anesthesia, medications, being in a different place, maybe not having your glasses, and being attached to that IV pole. Really important to always ask for help in moving around your room. And that leads us to mobility. So back when I was a novice nurse, early 90s, we kept everybody on bed rest. I don't remember ever walking any patients in 1990 after surgery, especially the first day or two. And of course, depending on your surgery and your orders, but for most people, we're going to be encouraging you to move, even if you don't feel like it right away. So it's just really important to help prevent clots and skin, promote skin integrity and all of those things. And I just want you to be thinking that you will be moving most likely shortly after your surgery. And also we do take skin integrity really, really seriously. And so now for the last poll question. What is the most common surgical complication for older adults? Delirium, very good. Yes, that is the correct answer. And we can move on to the next slide. So as Dr. Paul mentioned previously, delirium is if you can move to the next slide. Delirium is one of the most significant post-operative complications. It is an acute confusion state and usually has some sort of underlying cause, such as, I assume Annie can't move forward the slide, which shows that it can be medications, that you're not metabolizing the anesthesia. Also, where you may have a different sleep cycle where you're up all night and then people can become delirious from that. Of course, not being able to see or hear clearly can help increase your risk of having delirium and in being in pain. Like people that have dementia or Alzheimer's disease, it's often your short-term memory that is lapsing when you have delirium. So for Rosemary or myself, the first thing that we'll do is really try to create a trusting bond with someone who's in an acute confusional state and lock into that long-term memory. And so my first words sometimes are always, where were you born and raised? And I have several case studies where just being able to take that break, stop pushing whatever task that we're looking at, and to really lock in with their long-term memory so that you earn that trust as their nurse or their healthcare provider. So this is a significant thing. Right now we created these when we had the new building, something called About Me boards that says, what do you like to be called, and some information about yourself. And that was actually developed from my previous geriatric nurse navigator, who we have a Delirium About Me page that Rosemary will sometimes review with people so that we, as the staff members, get to know you as a person and can utilize that information. And for lastly, in the next slide, two other things that are so important, and it doesn't matter how old you are, is having an advance directive. We here at Sibley use 5 wishes, which is a very thorough legal document actually, that goes through all kinds of questions that you may not even think of that may come up if you're unable to speak for yourself. And having been a nurse practitioner for 20 years, I can't tell you how many times it takes, it's not until there's an emergency or a state where someone's unable to speak for themselves, and then I'm having to talk with the family members and they are just not clear with what the wishes would be about something specific. And it makes it really difficult and really hard on their children sometimes. So always good to think about. And lastly, that is Rosemary Trejo, who I feel incredibly lucky to work with every day. And she will help you with transitions back home. We also have special nurses called case managers that will help you to think of things. But always good before you have this surgery to really try to proactively think what you may need at home after you get back. That may just be something simple. And then very lastly, wanted to just say to my mom, Betty Seipel, who is watching, just thank you so much. She's always been so supportive of me and my nursing career, and I would not be here at this level working as a nurse without her. And now I'd actually like to introduce you to Rosemary and ask her if I missed anything or is there anything that she wants to add.
Thanks so much, Suzanne. I know we're going to be bringing Rosemary up as a panelist, and just want to remind everybody the Q&As at the bottom of the screen, and you can add any questions, and I appreciate them very much. So we'll start while we bring Rosemary up in. Well, I think Rosemary's here. So Rosemary, if you want to turn on, I know Rosemary, you don't want to turn on your video because I know you and you love just taking care of patients, or probably but we love seeing you. There she is. You can see she's taking care of patients actively. We're so happy to have you here, Rosemary. Is there anything additional that you wanted to highlight, or we can jump in?
Yeah, I just wanted to highlight that we're here to prepare you for any kind of surgery, and we're here to help you. So don't be frightened to come to Sibley. We have a great team. And as Dr. Paul and Suzanne said, we're prepared for anything that may come up.
Thank you so much, Rosemary. I want to start with a basic question that I think we answered throughout the presentation, but just, and Suzanne, I think you were talking a little bit about this, but can you define what a geriatric patient, like that's the 65 and above threshold?
Yeah, like I mentioned, technically it's 65 and older. Our program in the geriatric surgery standards actually focuses on 75 and older. Usually we focus in on people that are 80 and over because most of those people are more frail.
Fantastic. Somebody specifically asked if we can provide the slide with questions a patient should ask pre-operative, and I'm sure we can most certainly share that information out in our summary slide with this recording attached to it. This is a great question. Surgeons are performing increasingly complex and lengthy procedures on an outpatient basis. Is the PRIME program being used with elderly among these patients? Dr. Paul, I don't know if you wanted to address that.
Yeah, that is a great question. The PRIME program is still kind of in its infancy, and we start off with a select group of specialties so far. Most of the operations I do and within other specialties do still require inpatient care, so that's our primary focus right now. But your point is excellent, especially in the orthopedic world, neurosurgical world. A lot more complex operations are being done, and the patient goes home later that day. So you need to have some kind of system in place before and after surgery for their care. And I think these concepts of prehabilitation have really caught on in orthopedics and other specialties as well. I mean, all our nurse navigators we have in orthopedics really also focus on physical therapy before the operation, and focusing on improving nutrition. So I think even though it's not specifically the PRIME program, the concepts are certainly applied to all those patients who are going surgery.
Fantastic. It's another really great question that tees up to what you were just talking about. And I don't know, Suzanne or Rosemary, if you might be willing to answer this. Many older adults live alone. Sibley has a rehab facility for orthopedic surgery, but other than that, there appear to be no other rehab facilities, even private in DC. What are your recommendations other than hiring a private full-time nurse?
Rosemary, you want to take that?
Well, it's always a very difficult question because the caregiver, you need support through the surgery. And so instead of hiring a nurse, if you have a family member that helps, that can help a lot in your recovery. Because at the beginning of our program, we always solicit family members because it's a team effort. And that's key. But there's other resources like agencies, but mainly, that's the hardest part. But we try to get you more stronger before you leave here. That most of the time, families can do small things that help you to recover.
Thank you so much. Anything, Suzanne or Dr. Paul, that you'd like to add? I think we've seen also, I know,
Yeah.
like the Palisades Village, and there's some other great organizations in the community too that
Right.
that have developed some awesome networks. So it's important to explore all the things in your community. So another great question. In general, should older adults be prescribed antibiotics before or after surgery to prevent potential infection?
Yeah, I think in almost every case we do, I think that's almost the default, that no matter what the surgical procedure, it's sort of built into the whole preoperative preparations and orders that we give prior to surgery to give at least a single dose of prophylactic antibiotics. Sometimes, depending on the operation, if there's a significant potential infection during the operation, we'll even give additional doses. But yeah, I mean, that's for the most part, that's true. With rare exceptions, patients do need preoperative antibiotics before operations.
Thank you so much. I guess just in closing, if each of you could give your top piece of advice. I know we talked about a lot of really important things, but if our attendees were to walk away with one top piece of advice from each of your perspectives, what might that be?
Yeah, I think as I outlined in my summary slide, it's really important to, I think, have your goals of care in mind for older patients so that everything, the surgeons and the patients, their families are all aligned with what they hope to accomplish with the operation. It's not just fixing the problem, but making sure those goals are met. So hopefully your surgeon will allow time in their office for those kind of important discussions. And then again, the whole concept of rehabilitation, trying to get the patients in the best possible shape before surgery, and emphasizing the physical therapy and nutrition when it matters most.
Suzanne?
I think that was goals of care, of course, is really important to consider, but to just think about things proactively. I know it's probably overwhelming that you're being told that you have surgery, but to really try to optimize to be as healthy as you can well before something is an emergency, and then to always proactively think what may you need when you get home, so that because we would hate to have you to be readmitted or something like that.
Rosemary, anything you wanted to add that we didn't cover?
For me, I think one thing I would like for the viewers to remember is that get informed and know exactly what matters to them so that we know what matters to them and we can align everything that we do with them so that we're abiding with what their goals are too. But we're here I just want to make sure that they know that if they decide to come to Sibley, we're here to be ready to care for them.
Thank you. I know I, like many others on this call, have benefited from the exceptional care that Sibley provides and the extraordinary compassion. And I'm grateful for all of your time today and those of you who attended and our generous supporters that have made programs like Prime possible. We are just in debt of gratitude for you for allowing us to do these very important programs that help to provide even better outcomes for our patients and their families. Thank you so much for joining us today, and we will follow up by sending you this recording and that slide that was requested. Have a wonderful day. Thanks.